Here's something most people don't realize. After age 65, your body processes medication completely differently than it did at 40 or 50. Your kidneys filter more slowly, your liver metabolizes drugs at a reduced pace, you carry a different ratio of fat to muscle, which changes how long certain chemicals linger in your bloodstream. A dose that was perfectly safe at 55 can become genuinely hazardous at 72, even if nothing else changed, even if you've been tolerating it fine for years. And yet, the prescription often stays the same. The refill goes through automatically. Nobody pauses to ask whether this drug still makes sense for the body it's entering now. There's actually a term for this problem in medicine. It's called the prescribing cascade. A senior takes medication. That medication causes a side effect. Maybe dizziness, maybe confusion, maybe stomach pain. Instead of recognizing the side effect for what it is, another medication gets prescribed to treat that new symptom. Now you've got two drugs interacting, then three, then five. I've seen elderly patients on 14 different medications, and when I sat down and really untangled the web, half of them were treating side effects of the other half. The American Geriatric Society maintains something called the Beers criteria, a list of medications considered potentially inappropriate for older adults. It gets updated every few years, and every time it does, the list gets longer. Not shorter, longer. That should tell you something. So, let's talk specifics. These 5 medications appear in medicine cabinets all across this country, and every single one of them carries risks for seniors that far outweigh whatever benefit they're supposedly providing. I'm going to tell you what each drug does, why it becomes dangerous after 70, what the warning signs look like, and what safer alternatives exist. You deserve that information. Your mother deserves it too. Number 1. Diphenhydramine. Sold over the counter as Benadryl, ZzzQuil, Tylenol PM, and about a dozen store-brand sleep aids. This one infuriates me because you don't even need a prescription. You can walk into any pharmacy in America, pick this off the shelf, and nobody bats an eye. It's in allergy pills, it's in nighttime cold formulas, it's in those little blue sleep capsules that promise gentle, restful sleep. The word gentle is doing an enormous amount of heavy lifting on that label, because there is nothing gentle about what diphenhydramine does to an aging brain. Diphenhydramine belongs to a class of drugs called anticholinergics. That's a word worth remembering because it's going to come up again. Anticholinergic means the drug blocks a chemical messenger in your brain called acetylcholine. Now, acetylcholine is critically important for memory, for clear thinking, for coordinating muscle movements, and for regulating your sleep-wake cycle naturally. When you block it with a drug like diphenhydramine, yes, you feel drowsy. You might fall asleep faster. But the quality of that sleep is terrible. You're not cycling through the deep restorative stages your brain actually needs, and the side effects can be devastating. In seniors over 70, diphenhydramine commonly causes prolonged grogginess that lasts well into the next day. Dry mouth is so severe it contributes to dental decay and swallowing difficulties. Urinary retention, which in older men with enlarged prostates can become a medical emergency. Constipation, blurred vision, elevated heart rate, but those aren't even the ones that keep me awake. The big one is this: confusion. Acute, disorienting confusion that can look identical to dementia. I have personally seen patients brought into the emergency department by terrified family members who were convinced their mother was having a stroke or developing Alzheimer's. And when we ran through her medications, the culprit was Tylenol PM. She'd been taking 2 every night for 8 months because she had trouble sleeping. And nobody told her it was slowly poisoning her ability to think clearly. And there's a long-term consequence that's even more alarming. A major study published in JAMA Internal Medicine followed over 3,000 adults over the age of 65 for more than 7 years. The researchers found that cumulative use of anticholinergic drugs like diphenhydramine was associated with a significantly increased risk of developing dementia. Not temporary confusion, actual irreversible dementia. The higher the cumulative dose, the greater the risk. Let that settle for a moment. A drug you can buy without a prescription, marketed as a harmless sleep aid, may be contributing to permanent cognitive decline in the elderly. If my mother told me she was taking Benadryl to sleep, I would drive to her house and remove every last pill. I'm not exaggerating. I would replace it with a conversation about sleep hygiene, keeping a consistent bedtime, limiting screen exposure in the evening, keeping the bedroom cool and dark. If she needed more help than that, I'd explore low-dose melatonin under supervision or cognitive behavioral therapy for insomnia, which has strong evidence behind it and zero anticholinergic risk. Please go check your medicine cabinet tonight. Check your parents' medicine cabinet. Look for diphenhydramine on the active ingredients label of every over-the-counter bottle in there. You might be shocked at how many products contain it. Number 2. Muscle relaxants, specifically Cyclobenzaprine, sold as Flexeril, and Metaxalone, sold as Skelaxin. Here's a scenario I see constantly. A 73-year-old woman bends down to pick up a grandchild and feels something grab in her lower back. Sharp, nasty pain. She goes to her doctor, or maybe to an urgent care clinic, and she walks out 20 minutes later with a prescription for a muscle relaxant and instructions to rest for a few days. Sounds reasonable, right? It's one of the worst things you can prescribe an elderly person. Cyclobenzaprine is structurally almost identical to older tricyclic antidepressants. It crosses into the brain very easily, and once it's there, it causes heavy sedation, dizziness, confusion, dry mouth, and impaired coordination. The sedation alone would be a problem. Drowsiness in a 70-year-old living alone is a fall waiting to happen. But the combination of sedation plus dizziness plus impaired coordination turns a simple backache into a broken hip. And a broken hip in a person over 70 is not a minor injury. Up to 30% of elderly patients who fracture a hip die within 1 year. 30%. The drug also lingers. In a younger person, cyclobenzaprine clears the system relatively quickly. In an older adult with slower kidney and liver function, it can hang around for days, accumulating with each dose, building sedation on top of sedation until the person is essentially walking through fog. And here's what really bothers me. The evidence that muscle relaxants actually work for back pain in the elderly is thin, genuinely thin. Most acute back pain in older adults resolves on its own within a few weeks regardless of treatment. Gentle movement, careful stretching, heat application, and short-term use of acetaminophen at appropriate doses, that combination handles the vast majority of cases without introducing any fall risk whatsoever. If my mother pulled a muscle in her back tomorrow, I would bring her a heating pad, set her up with some gentle stretches I trust, and check on her every day. A muscle relaxant would never enter the conversation. The risk-to-benefit ratio doesn't come close to making sense. Number 3. Long-acting benzodiazepines, specifically diazepam, which you probably know as Valium, and clonazepam, sold as Klonopin. Now, I want to be careful here because I know some of you watching this may currently take one of these medications, and I am not telling you to stop cold turkey. Benzodiazepine withdrawal can be medically dangerous, and stopping abruptly without guidance is genuinely risky. If this section concerns you, please bring it up with your doctor and make a plan together. That's important. That said, benzodiazepines in the elderly terrify me. These drugs were designed to treat anxiety, panic attacks, seizures, and sometimes insomnia. They work by amplifying the effect of a calming neurotransmitter called GABA in the brain. They are extremely effective at producing relaxation. That's the problem. They are too effective, and in a 70-plus-year-old brain, the relaxation tips into dangerous territory fast. Long-acting benzodiazepines like diazepam have something called an extended half-life in older adults. In plain language, the drug stays active in your body far longer than it would in a younger person. Diazepam's half-life in a senior can extend beyond 100 hours. That means days after taking a single pill, active drug is still circulating, still sedating, still impairing balance and judgment and reaction time. If you're over 60 or caring for an elderly loved one, this information could be life-saving. Falls, car accidents, profound confusion, memory blackouts, these aren't rare side effects at this age. They're predictable outcomes. The medical literature on this is overwhelming. Benzodiazepine use in the elderly is one of the strongest, most consistently documented risk factors for fall-related injury and hip fracture. period. Here's a question for you. Has anyone in your family been prescribed Valium or Klonopin and told it was safe to take indefinitely? Because I hear that story again and again, and it breaks my heart every time. Long-term benzodiazepine use also carries cognitive risks that mirror what we discussed with diphenhydramine. Multiple studies have linked chronic benzodiazepine use in older adults with increased risk of dementia. The mechanism is different, but the outcome rhymes, clouded thinking that may never fully clear. For anxiety in seniors, I vastly prefer starting with non-drug approaches, structured counseling, breathing techniques, regular low-impact exercise, walking, water aerobics, tai chi. All of these carry genuine anti-anxiety benefits with no fall risk attached. When medication is truly necessary, a short-acting option like low-dose buspirone, which isn't sedating and doesn't impair balance, is a far safer conversation to have. My mother went through a period of significant anxiety after my father passed away. She asked me about Valium because a friend had recommended it. I said absolutely not, sat with her, and helped her find a therapist she trusted instead. Took about 3 weeks before she felt a difference. Took about 3 months before she told me it was the best decision she'd made in years. No pills, no fog, no risk. Number 4. The one I said keeps me up at night. Proton pump inhibitors taken long-term. Omeprazole, lansoprazole, pantoprazole. You know them as Prilosec, Prevacid, Protonix. I can already hear some of you saying, "Wait, my doctor told me to take that forever. I've been on it for 6 years. It's just for heartburn. How dangerous can it be?" And that's exactly why this one haunts me. Because the drug itself, used short-term for the right indication, is fine, genuinely helpful. 4 to 8 weeks for a healing stomach ulcer or severe acid reflux. That's appropriate medicine. The problem is that 4 to 8 weeks somehow becomes 4 to 8 years and nobody ever revisits the decision. Proton pump inhibitors work by dramatically reducing stomach acid production. Your stomach then heals. Great. But your stomach acid isn't just there to cause you discomfort, it serves essential biological functions. It breaks down food so your body can absorb nutrients. It kills bacteria and pathogens that you swallow every day. It signals downstream digestive processes that keep everything moving properly. When you suppress that acid for months and years, things start going wrong quietly. Calcium absorption drops, and long-term PPI use has been associated with increased fracture risk, particularly hip fractures, vertebral fractures, and wrist fractures. In a 75-year-old woman already losing bone density, adding a drug that further undermines calcium absorption is pouring gasoline on a slow fire. Magnesium levels can plummet, leading to muscle cramps, irregular heartbeat, and seizures. Vitamin B12 absorption decreases, contributing to fatigue, nerve damage, and cognitive changes that once again mimic early dementia. There is also growing evidence linking long-term PPI use with increased risk of Clostridium difficile infection, a severe, sometimes fatal intestinal infection that disproportionately affects the elderly. And then there's the kidney data. Several large observational studies have connected prolonged PPI use with chronic kidney disease progression. The mechanism isn't fully understood yet, but the pattern is consistent enough that the nephrology community has taken notice. My mother was put on omeprazole after a bout of gastritis 5 years ago. When I reviewed her medications during a holiday visit, she was still taking it daily. The gastritis had resolved within weeks. Nobody had told her to stop. She just kept refilling it because the bottles said to. I tapered her off gradually. We adjusted her diet. Smaller evening meals, elevating the head of her bed slightly, avoiding tomato sauce close to bedtime, which she took as a personal insult given how she feels about her marinara. And her reflux stayed manageable without the drug. Talk to your doctor about whether you still need your PPI. Ask the question directly, is this still necessary or can we try stepping down? You might be surprised by the answer. Number 5. Sliding scale insulin used aggressively in elderly type 2 diabetics, combined with sulfonylureas like glipizide or glyburide. This one is slightly more nuanced, but it matters enormously. The danger here isn't the concept of blood sugar management. That's important at any age. The danger is the target. The tightness of control that doctors sometimes chase in elderly patients as though they're treating a 45-year-old. Glyburide in particular is flagged on the Beers criteria specifically for older adults. It's a long-acting sulfonylurea, meaning it stimulates insulin release for an extended period, and in elderly patients with unpredictable eating habits, reduced kidney clearance, and diminished ability to recognize symptoms, that extended action translates to hypoglycemia, low blood sugar, and hypoglycemia in a 78-year-old living alone is a catastrophe. The symptoms start with shakiness, sweating, confusion. If nobody's there to notice and intervene, it progresses to falls, loss of consciousness, seizures, and death. I've treated elderly patients brought in by paramedics after neighbors found them collapsed on the kitchen floor, blood sugar in the 30s, because their glyburide dose hadn't been adjusted in years and they'd skipped lunch. Many seniors and their families don't realize that aggressive blood sugar control in the very elderly can cause more harm than the slightly elevated sugar it's trying to prevent. The American Diabetes Association has acknowledged this. Their guidelines now recommend relaxed targets for older adults with limited life expectancy or significant comorbidities. An A1C of 7.5 or even 8 may be perfectly appropriate for someone in their late 70s. Chasing 6.5 with powerful medications in that population risks hypoglycemic episodes that can kill. If my mother were diabetic, I would advocate fiercely for conservative management. Metformin, if her kidneys allow it, dietary modifications, regular gentle activity, and a blood sugar target that prioritizes safety and quality of life over textbook perfection. Glyburide would be off the table entirely. And any sliding scale insulin regimen would be designed with wide margins, not razor-thin ones. So let's bring this home. 5 medications. Let me list them one final time. Diphenhydramine, the hidden anticholinergic lurking in your sleep aids and allergy pills, quietly contributing to confusion and cognitive decline. Muscle relaxants like Cyclobenzaprine, turning a simple backache into a fall risk with minimal actual therapeutic benefit. Long-acting benzodiazepines like diazepam and clonazepam, sedating an aging brain into fracture territory and potential dependence. Proton pump inhibitors used indefinitely, silently draining bones, kidneys, and essential nutrients month after month. And aggressive glucose-lowering regimens with drugs like glyburide, chasing a number on a lab report while introducing life-threatening hypoglycemia. None of these drugs are evil. Every single one serves a legitimate purpose in the right patient, at the right dose, for the right duration. The problem is that prescriptions outlive their usefulness. The problem is that aging changes the equation and nobody recalculates. The problem is that refill is the easiest button in medicine, and let's reconsider takes time that the system doesn't always provide. You can be part of the solution. If you are over 70, bring every medication, prescription, and over-the-counter to your next doctor's visit. Put them all in a bag, set them on the table. Ask your doctor to look at each one and tell you, do I still need this? Is this still safe for my body at this age? Is there a better option? If you're a son or a daughter caring for an aging parent, be their advocate. Go to the appointments with them. Write down the questions ahead of time. Don't assume that because a drug was prescribed by a doctor, it was prescribed with your parent's current age and current body in mind. Doctors are human. They're overworked. They miss things. Your vigilance could be the thing that catches what gets overlooked. My mother is still gardening, still making that sauce, still calling me about vegetables, and I intend to keep it that way for as long as I possibly can. Not by adding more pills to her routine, but by making sure every single pill she takes has earned its place. You can do the same for the person you love. If this video helped you, I'm asking you to do 3 things. First, subscribe to this channel because we put out content like this every single week, focused specifically on keeping seniors safe, informed, and healthy. Second, share this video. Send it to your brother, your sister, your adult children, anyone helping care for an aging parent. This information shouldn't stay buried in medical journals. Third, drop a comment below. Tell me which medication surprised you. Tell me if you found something in your cabinet tonight that concerns you. I read every single comment, and this community we're building matters. Take care of your people. They took care of you first.